The next surgery that we are going to talk about is what are the procedures that we do for glaucoma. So, as you see here, what procedure has been done here? Trabeculectomy has been performed. Okay, trabeculectomy has been performed. Now, how do I know that this is a trabeculectomy? Two things. Now, number one is this one. Number two is this. So, what is number one? Number one shows me the filtering bleb. Okay, it shows me the filtering bleb. Number two shows me the peripheral iridectomy. Okay, peripheral iridectomy. Okay, so what is this filtering bleb and what is the role of this peripheral iridectomy? Now, let us see the cross section of the eye where the trabeculectomy is being performed and how an alternative route for aqueous outflow is established. Okay, so now you know that aqueous is produced by the ciliary processes. It comes into the PC, then through the pupil into the AC to go into the angle, the trabecular meshwork, and out into the episcleral veins. And we also know that the maximum resistance is at the juxtacanalicular portion of the trabecular meshwork. So, there is some resistance there, that is why even the normal IOP is generated. And when the IOP is very high, that means the resistance is very high. Okay. So, if we remove a little bit of the trabecular meshwork, definitely the resistance will become less and thereby the pressure also will fall. That is the whole idea. So, what are we going to do? We are going to remove this trabecular meshwork. Okay, we are going to remove this trabecular meshwork. But are we going to remove 360-degree trabecular meshwork? No. See, if this is my eye, my angle is 360 degrees. So, my trabecular meshwork also is 360 degrees. Now, if I remove entirely, I will get hypotony and I will get hypotonic maculopathy. I do not want that. So, I am going to remove the trabecular meshwork in just 1 clock hour. Only in that small area I want to remove. So, when I remove this, what happens? The aqueous faces lesser resistance and it is going to come out. Yes, now it is going to come out because I am going to make a full thickness resection. So, when it comes out, where does it drain? So, now it is going to lift up the conjunctiva and get accumulated here, that is in the subconjunctival space. Okay. So, this is my subconjunctival space and then it gets absorbed into, as always, the episcleral veins and the conjunctival veins. Okay. So, this thing that it raises is called as the filtering bleb. So, that is what you see here as the filtering bleb. Okay. So, that is the filtering bleb. Alright. Now, why is a peripheral iridectomy being performed? So, exactly overlying where I am removing the trabecular meshwork, we are going to do a peripheral iridectomy. Why? Now, supposing I do not do, look at the cross sectional picture. The iris can move forward and block that opening. Yes. So, I have an opening here. This iris can just go in and block that opening. Then the whole purpose of doing a trabeculectomy is lost. So, what I do is we are going to remove a small bit of the iris there. So, that is why now two reasons. One is the iris will not go and block and also the aqueous has a free flow even from the PC through that opening into the AC. Now, removing the trabecular meshwork reduces the resistance. So, that is the primary reason why this is the surgery of choice in POAG. Why? The resistance is reduced. Now, this is also the surgery of choice. Which one? This trabeculectomy is a treatment of choice even in PACG, primary angle closure glaucoma. Why? Again for two reasons. One is the resistance is reduced and number two, now because you are doing this peripheral iridectomy here, even if there is a block at the level of pupil, which happens in angle closure glaucoma, there is always a way for the aqueous in the PC to come into the AC. Okay. So, I already explained this pupillary block mechanism in the glaucoma section. Okay. So, if you watch that, you will know what is the mechanism that is happening in angle closure glaucoma. So, when this peripheral iridectomy will make sure that pupillary block is bypassed. Is that clear? Now, some people must be wondering, ma'am, if we do this peripheral iridectomy here, yes, as you see in this cross section, ma'am, won't the iris fall off? Guys, bache, this is only a cross sectional image. Now, when you see the main image, the frontal picture, See, only this bit I am going to remove. So, the entire rest of the iris is there, no? So, iris will not fall off. So, when I take a cross section at that area, you will see that the iris is missing, alright. So, that is exactly what you are seeing here. So, that is exactly what you are seeing in this picture. So, you are seeing a peripheral iridectomy. So, this is a surgical iridectomy which is different from a laser iridotomy, okay. So, you are seeing a filtering bleb and a peripheral iridectomy. Now, because this conjunctival bleb is overhanging on the cornea, you can see that the tears accumulate here. So, the lactoferrin with the iron content deposits in the epithelium, corneal epithelium, forming that Ferry's line. You remember we discussed in cornea Ferry's line. So, that is the reason, okay. Now, sometimes what can happen, now I have made a opening, okay, I have created a surgical wound. Now, if the fibroblasts repair, okay, and they repair overzealously, what can happen is this will get filled up, okay, this will get filled up. So, if this gets filled up, this filtering bleb area, the trabeculectomy, everything, my trabeculectomy is a failure, okay. So, to make sure that my trabeculectomy is patent, we use mitomycin C during surgery. So, what is it? Mitomycin C is, as you know, is an antimetabolite and an antifibroblastic agent. So, it will, so what you have to do is you have to apply this on the sclera, yes, when you are doing the surgery, and wash it off nicely, okay. So, mitomycin C is going to make sure that your trabeculectomy will not fail and will remain patent. So, when we use mitomycin C, the procedure is called as augmented trabeculoplasty, okay. We are augmenting the effect of trabeculoplasty. Now, this is most commonly used, even 5-fluorouracil can be used. Now, of late we also have something called as ologen. Ologen is nothing but a small, a piece of collagen that comes. So, you just leave that collagen in that filtering bleb area, okay. So, that makes sure that the fibroblasts do not proliferate and close the trabeculectomy site. So, what are the three things that are used to enhance this trabeculoplasty and keep it patent? Mitomycin C most commonly, also 5-fluorouracil, and also this ologen, and ologen is nothing but collagen, okay, right. So, this is about trabeculoplasty. Now, there are some kinds of glaucoma which are bound to fail, okay. I definitely know my trabeculectomy will fail or it would have already failed. Now, how to manage such a scenario? So, if I know that it is bound to fail, my trabeculectomy is bound to fail or it has already failed, then we use this glaucoma drainage device called as GDD, also known as cetons or aqueous shunts, okay, aqueous shunts. Now, what is this? Now, let us see what it is. Now, this is a GDD, okay, this is a GDD. So, it is placed extraocularly, commonly between the superior rectus and the lateral rectus muscle. It is placed beneath it, okay, because it's a huge one, and it's got a little tube that goes into the anterior chamber, right. So, the mechanism is simple. By capillary action, the aqueous is going to come out and it will get collected in this little space offered by this device, okay. So, it gets collected there and is absorbed by the episcleral veins. The only thing is the resistance here at the trabecular meshwork is bypassed because now it comes out through the tube, and also there is no filtering bleb here. The device offers a space for accumulation and absorption of the aqueous, alright. So, this one in particular, this one is called as Baer-Wells valve, okay, this is called Baer-Wells valve, glaucoma valve. But the most commonly used glaucoma valve is what we call as Ahmed glaucoma valve, okay. So, this is Ahmed glaucoma valve. So, when you see it, how to identify it? It is going to look like this tiny mouse, no? The mouse that we use for our computers, it looks like that, but it's a very tiny one, okay. It's a very tiny one, and it will be placed sutured onto the sclera in the space between the superior rectus and the lateral rectus, and the tube will go inside, okay. So, you can see the tube inside as in this one. Can you see the tube? Yes, the bevel margin, So, that is in the anterior chamber. Is that clear? So, this is GDD. Now you have Ahmed glaucoma valve. What are the other names? You have the most common I said is Ahmed glaucoma valve, AGV. Then the one I showed you first, Behr-Wells valve. Then you have Molteno implant, Shockett shunt, Krupin's valve. Okay, so these are various names, okay, as they were devised by different ophthalmologists. Okay, so these are the various GDDs that are available, GDDs or setons. Okay, there is one indigenous one that is from India, which is called RD. Now, what is RD? Aravind Aqueous Drainage Implant. Okay, so this is from the Arvind Eye Care System. So this is also a glaucoma drainage device. Now we've got what is called as MIGS. What is MIGS? Minimally invasive glaucoma surgery. Okay, MIGS. Now this device comes under MIGS surgery. Now what is this device? This is called as an express, okay, express shunt or an express mini shunt. You can say express shunt or express mini shunt. Now an express mini shunt in situ, you can see it here, right. So there is no filtering bleb involved. See, it's a very tiny thing. You don't do much of manipulation at all. So all that you have to do is just open up the conjunctiva, keep it here and insert it. So you can see it in situ opening into the anterior chamber. Now what is it made up of? It is made up of stainless steel. But what is the speciality of this stainless steel? It is an MRI compatible stainless steel. Okay, so it's absolutely safe to be used in if a patient is going for an MRI. Okay, so this is express mini shunt and this is exactly how it looks like. Okay, it looks like the small nail that you drive on the wall into the wall. No, it looks exactly like this. So this is the inner component, this is the external components. You have a little flange. So the flange is there so that it holds it so that it will not come out. You know, it will not extrude. So this is express mini shunt. Then we also have a another shunt which is called as Solex shunt. Now Solex shunt, the peculiarity of the Solex shunt, two things. One is it is made up of gold, okay, and it opens into the suprachoroidal space. So that means it increases which outflow? It goes into the uveoscleral outflow. Okay, so these are two innate things you need to know about Solex shunt. Now there is a surgery called as viscocanalostomy, which is also part of the MIGS. Now what is viscocanalostomy? You inject viscoelastic into the Schlemm's canal, okay, so that it gets dilated. So that is also a minimally invasive glaucoma surgery, okay. And there is another, so these are the various surgeries that you have for glaucoma, okay. So this is about minimally invasive glaucoma surgery, MIGS.